This is M mode where the movement of heart, this graphic representation can let you know about the movement of heart. What is that basics? I'm just going to let you know the few basics because we'll be uh, touching everything here today, how to you can play with the keys to get ultrasound image. For that we must be knowing the basics of ultrasound. So piezoelectric effect is the basis of ultrasound where specialized crystals are used. If we agitate that crystal with the help of that physical movement, these crystals will produce electricity. In the same manner, if they are agitated with electricity, they will produce ultrasound, and this is called piezoelectric effect. These crystals are arranged in what is an ultrasound transducer. Multiple crystals are arranged here, and they are stimulated with that electrical current, and they produce those sound waves which go into the body and which is more than 20,000 hertz, and they are reflected back at each interface. And due to that reflection, there are gray and black areas in that picture, and we get an ultrasound image. So very important fact that we for diagnostic ultrasound we use from 1 megahertz to 15 megahertz really. Even now people are for corneal ultrasound doing 30 megahertz or 40 megahertz, very high frequencies are being used. But the most commonly in radiology, in medical imaging, in peripheral vascular study, we are using 1 to 15 megahertz. And an important fact, the higher the frequency, shorter is the wavelength, and lower the frequency, longer is the wavelength. So the low frequency probes, they have more penetration, and higher frequency probe, they have less penetration. But another fact, the higher the frequency and better picture we get, better is the resolution. So what can we do? So there is a compromise that we use a middle order frequency to have both a good penetration to get to that structure and an acceptable resolution to see that picture. So that's very, very important fact while playing with the keys, fidgeting with the ultrasound probe, that which probe must be used in this patient. So the velocity of ultrasound in body, that is 1540 is an average in the soft tissue. All this is a very important fact while doing Doppler and ultrasound. So I told you that lower the frequency, more penetration, higher frequency, less penetration, at the expense of this is that resolution. So what to do? Is an obese patient? What will we use? Low frequency or high frequency? We'll use low frequency. So not that low to lose the good quality of the picture. And if there is a very thinly patient, we are having that benefit. We can use the higher frequency, can have a very good picture, and it can penetrate enough in that patient. So that's an important factor. A very obese patient comes to you and trying to use the higher frequency, even you can't see it, penetrate the thigh of that patient, a very big thigh. So you have to use sometimes even the curvilinear probe, low frequency probe, if there is obese patient is there. Normally there is a general concept that always use a flat probe, high frequency probe for the limbs, general impression. But sometimes you put the flat probe and you get nothing. You can't even get to the vessel. You can't see the vessel. So much fat is there. So it's very important to know the tricks and the tips how to scan that patient and get a good picture. So there are different knobs, because my topic given to me was novology and how to fidget with that Doppler machine and play with the keys. So there's a knob that is gain, which makes the picture bright and dark. So if your picture is very dark, you will be losing so many structures. It's very bright, everything will be jumbled up and you won't be able to make anything out of the structure, will be mixed up all. So normally, if this is a TGC curve, there is a time gain compensation. The idea is behind time gain compensation is the echoes which are reflected back in the body from the nearest part, they get weakened and they are minimally weakened, but which are coming back from the farthest part, they have suffered the maximum weakness, so they should be compensated for that weakness. To compensate that, we always keep our TGC probe, the time gain compensation probe, in such a manner that the echoes coming from the nearest part of the body, they are compensated minimally. But which are coming back from the farthest part, they are get maximum compensation. So people in Lahore, they should get minimum compensation. In the South Punjab, Rajanpur, they should get no compensation. That should be the basic idea. It's happening vice versa. Everything is concentrated. So I'm sorry, I'm not going to the politics. So so the echoes coming back from the nearest part should get minimum compensation. The farthest part should get the highest compensation to get a good image, a good impression. That is very important. Get a good picture. So ultrasound started with A mode and graphic representation. Then with the advent of new technique, new machine, what we do, we send electrical impulses to this transducer having piezoelectric crystals, electrical energy converted into sound waves, go into the body, come back, go to the machine receiver, then scan converter, and image is seen on the ultrasound machine. And we can save the image in machine's memory or get a printout. That is the whole procedure. How do we get a good image? We started seeing just A mode, first with from obstetrics, only fetal parts, fetal head, and with the advent of now we can do everything from head to toe. We are scanning from everything, peripheral vascular, brain scan. Doppler, the idea of Doppler was evolved by Christian Doppler, a scientist, who said that when a sound wave is received by a person and the source is moving, like ambulance siren, train siren, the frequency increases. If it's going towards the receiver, the frequency increasing. Is going away from the receiver, the frequency is decreasing. That's the basic idea thrown by that brilliant scientist. So if the going towards the receiver, the frequency is increasing. If no movement, frequency is not changed. If it's going away from the receiver, the frequency is decreasing. You see, it's concentrating, increasing, here it's decreasing. So that's the idea of Doppler. So while this car is going towards the receiver, the frequency is increasing. It's going away, decreasing. That's the basic idea. That's called a positive Doppler shift. If it's moving towards the probe in the ultrasound, I'll come to ultrasound now. If these RBCs, this is the ultrasound probe, these are the RBCs, basically the RBCs which are reflected back, ultrasound beam is reflected back by these RBCs. If the blood is moving towards the probe, that is a positive Doppler shift. Its frequency will increase. So positive Doppler shift. And if it's moving away from the probe, it will be a negative Doppler shift. And in machine setting, it's said that above the baseline positive, below the baseline negative. And again in the machine setting, we have set the machine in such a manner that anything going towards the probe, it appears red. It's not the arterial or venous. It's a misconception that anything coming toward becoming red is arterial. No. Anything coming toward the probe is red, going away from the transducer, that is blue. Anything coming towards the probe is above the baseline, other is below the baseline. That's important factor you have to keep in mind. And then we have CW and PW. CW, where the two separate crystals, they transmit and receive. And here we have less information about the location of the structure, but we can get very, very high frequencies. So in echocardiography, there are very high frequencies. PW, the same crystal is emitting ultrasound and receiving ultrasound. there is a gap between the two, and here we have limitations, we have a picture, location, but we can't measure very high velocities. Very high velocities for who need that CW. So that's a question. I don't want to teach physics, but it's very, very important to know. This picture is for Doppler because here is written 2F, and 2F means because we are dealing with the reflected beam. The ultrasound beam is coming from the probe to the vessel and coming back to the transducer. It has to travel double the distance. That's why it is having 2. And this cos theta is again, it will come everywhere. You can't leave this cos theta. If you don't understand cos theta, you can't understand Doppler, I tell you. You can't perform, you are not entitled to perform the vascular Doppler because cos theta 90 is 0. The mathematicians know that. We doctors are very bad in mathematics and physics. That's why we became doctors. So, but I tell you one thing, cos theta 90 means 0. So if you try to do Doppler at 90-degree angle, you will get 0 information. Ultrasound picture is best seen if you scan at 90 degree. You get the best picture if you place your probe at 90 degree. But for Doppler, you need less than 90. If anybody is trying to do at 90 degree, no Doppler information. Erroneous information, erroneous diagnosis, as Dr. Yasar were telling you that somebody said DVT and vascular insufficiency, this and that, because the person didn't know the physics. So this picture tells you that if you are placing your probe in this manner, then you will get nothing because it is 0. You have to make an angle with the vessel that we will discuss in image optimization, the next forthcoming slides. So because cos theta 90 is 0. And another thing, that if our angle is less than 60, we can get better picture because error is minimum when it's less than 60. When angle is 62, there is rocketing of error. When error is, you should see here, up to this graph reflects, up to 60, the error is very low. The moment it goes beyond 60, there is rocketing of error. So you are scanning at 70-degree angle, you get very high error. I'm saying velocity is 35, you will say it's 90, because you angle at a different angle. You scan that patient, so angle is very, very important. I told you cos theta. If you forget cos theta, forget about ultrasound. So I told you that flow is seen at 10, 20, 30, 40, 50, 60, up to 60. It's very good. From 70 to 90, rocketing of error, and at 90 is 0. Very important point. You see here ultrasound beam is striking this vessel at an angle. You are getting highest frequencies. Angle is highest. You see probe is here. These green, yellow colors are reflecting very high frequencies. And here is red, sufficiently good frequency. The moment we come at 90 degree, no color is seen, so no flow. Power Doppler. Then with the advent of newer techniques, people introduced power Doppler, that it should not be angle dependent. We should get some information where flow is there, present or not, is qualitative. For qualitative analysis, power Doppler is very good. That is not angle dependent. You just want to know the presence or absence of flow. You are not interested to measure or to quantify the velocity. But if you want to have quantitative analysis, you must be having that angle and color Doppler and spectrum. And spectrum is the basis of that. This is a spectrum. Every vessel in the body, from head to toe, has its own specific Doppler signatures. Whether middle name is changed, first name is changed, surname is changed, we will diagnose immediately. As banker see the signature, he tells that it's a fake. In the same manner, we will come to know that there is a departure from normality. This is not normal, but we have to first recognize the normal signature of every vessel. If you recognize normal signature of every vessel, you will immediately come to know. The moment you will place your probe, turn on the Doppler, get your proper angle, measure the spectrum. This is the spectrum. That is where color is to locate the vessel. Color is not to diagnose, I tell you. There are some color artifacts which help you diagnose ultrasound Doppler. But the basis of without doing spectrum, you can't quantify the difference and the problem, the disease. So this Doppler signature, you must know these, and wherever these are changed, a good Doppler specialist or good clinician will immediately come to know that what is the disease, whether it's proximal disease, distal disease. We'll come to that. What happens to spectrum if disease is upstairs? And what happens to spectrum if disease is downstairs? We can diagnose that immediately. So if it is laminar flow means smooth flow, then obviously you get a good spectrum, a clean window. If it's disturbed flow, then obviously this spectral broadening, this is called the spectrum is thickened, broad. Lot of velocities are mixed up here, and very turbulent flow will come to that point. And there are, to measure, number one, we measure the velocity. To measure the velocity, we need a definite angle. But if you are not getting proper angle at certain places, then you won't go for velocity, you will go for these ratios. But it should be less than 60, but you go for ratio. As in obstetrics, sometimes it's not possible to have a definite angle. In peripheral vascular, sometimes with the convex curvilinear probe, then you can have this resistive index. This reflects the resistance offered by that vessel to the flow of the blood. Highest the RI, more resistance is offered. Lowest the RI resistive index, less is the resistance. In the same manner, PI, the pulsatility index, and SD ratio, systolic, diastolic ratio. This is systole, the upward stroke is systole, and this is diastole, the downward stroke. This is this part of the spectrum. This is the classical spectrum. This is systole and this is diastole. This is maximum systolic frequency and this is end diastolic. These terms will be used everywhere while diagnosing on Doppler. Color Doppler, the going towards the probe is red, away from the probe is blue, and here is the probe. This is come toward the probe, going away it is blue, and power Doppler we discussed already this. So what is a parabolic flow? In ideal world, in a river, if you see a river, the flow, the central flow is the highest, and the banks of the river, they are offering resistance to the flow, right? We know this fact. The banks of the river, they offer resistance to the flow. So the slowest flow will be on the periphery. In the center, the flow will be, and it will be a laminar flow, the parabolic flow, and this is a smooth flow where vessel is not having any plaques. No calcium plaques, no irregularity, smooth walls. We determine the presence, absence and solidity of vascular disease based on Doppler flow patterns. So you see here in the periphery slow, in the center the fastest, because the sides of the river, the banks, they are offering resistance. So if we want to measure the flow, where to place the cursor? This line when we start scanning, in every machine we will show you in practical session, is a cursor. You have to place this cursor in the lumen of the vessel. So what if you open the cursor, open this spectral volume from one wall to the other wall, then you will get a very thick spectrum. You are mixing up all high, low frequencies. You won't get a very crisp, fine spectrum. So we'll discuss it. If you want to have a nice, very crisp spectrum, having a systolic window and thin line, you know that to get this nice you need a small sample volume, as in that river, the banks, just as the banks of the river are offering resistance, in the same manner, the vessel walls, they are offering resistance to the blood flow. So this is a central flow is the highest and the peripheral part is the lowest. So if you open that sample volume very wide, you will get a spectral broadening, and if you take put a small sample volume, you will get nice, a good window of a nice spectrum. That's the desired one. So there is other term used that the plug flow and the normal parabolic flow. The plug flow is when heart contracts. It pushes the whole blood in one wave, and so 90% blood is moving in spite of the resistance offered by the walls. The 90% particles, the RBC is moving with the same velocity. You see little bit of difference here. This is called a plug flow, and that is the basis of the systolic flow. That's what we get in that systolic peak. You see, you will be talking about systolic peak. What happens when the heart contracts? Then there is plug flow, and all the RBC moving with the same velocity, and you get a systolic peak, and then it drops down. And in diastolic flow, you get that thick, and then this picture becomes there. Some velocities slow, some velocities that with high velocity. So normal lower arterial multiphasic waveform, this triphasic waveform will be seen when you start scanning either upper limb or lower limb, and there is a vasoconstriction, we know that, because uninterrupted supplies to VIPs. What are the VIPs? Worker class, they don't get uninterrupted supply. So VIP is the brain. So carotids, they have uninterrupted supply. Always very good supply there. But to worker class, to the legs, the feet, there is a vasoconstriction. So there is high resistance flow. You see, this in diastole you see little bit of flow. There is this peak is there, then reverse of flow, then third wave is here. This is called a multiphasic waveform or triphasic waveform because there is vasoconstriction in the peripheral, in the limb vessels. If you start doing exercise, what happens? There is dilatation. If you wash your feet with very warm hot water, there is a vasodilatation. That's why it's said that the old people, they start taking a bath, they should first put water on their body. If they straight away put their head under the shower, then lot of energy in the brain and lot of blood will be pushed to the brain, and if there's some weakness, there will be most of the strokes they happen in the washroom, you know. Most of the strokes in the morning they happen in the washroom, the old people. Why? Because 90% people they put their head under the shower, hot water. So vasodilatation, aneurysm, weak parts of they will rupture and there will be stroke. So it's said that always first make your feet wet, legs, rest of the body, so there is a vasodilatation and whole blood is pooled in the limbs and in the body. Little blood is left to rush and to go to the brain. It's the Bible. So if you start exercise or put hot water on your limbs, there will be vasodilatation and then good diastolic flow. Triphasic waveform is lost. The patient has come after walking 200 meters and you immediately lie down, I am having very busy clinic, going to start your scanning and put your probe, you will see there is good diastolic flow, there is spectral broadening, having that must be some proximal stenosis, wrong diagnosis. Patient must take rest for some minutes. Don't patient has come huffing and puffing from the street in a rickshaw and rushing to you. Doctor, my time in oh yes, I'm very busy time. I can't wait for you. Lie on the bed and put your no. You have to give time to the patient, otherwise you will be getting erroneous information. In ideal world, we are talking all that in ideal world. When the wall is smooth, no calcium plaques, but does patient come with a smooth wall? No. When patient come for peripheral vascular disease, they are old people having some problem. So if you are living in an ideal world, we won't get those classical cases. Normal people won't come to the doctor for peripheral vascular studies. So if in an ideal world you get this crisp, very good picture, right? Smooth wall. But what happens if that wall is having plaques and irregular wall? Can't you have that smooth pattern of the floor? You can't have, you see calcium, wall is irregular, and then you get this turbulent flow. You can't get, I showed you a river with very smooth flow, having parabolic flow, laminar flow, but in real world, you see this splashing of water. In the same manner, you can hear that splashing when you turn on your Doppler noise. That's the non-laminar flow. You see here a lot of turbulence because it's striking against the hard rocks and in the same manner the calcified plaques. So what will you get? You get red and blue because there are plaques. So in the same manner there is a carotid bulb. This swirling movement, the room of the dome, that swirling movement won't give you the very good, nice red color or the only blue color and very nice crisp spectrum. You can't get a crisp spectrum. You should know where you are, which part of the vessel are you negotiating. That's important. If you are having that turbulent flow, you can't get that crisp. You will get to and fro movement because you are having blood is striking against the rocks. So it's not giving you one color. This non-laminar turbulent flow is there. So if this tortuous like a snake, running like a snake, some rivers are, the old river, they are running like a snake. So where there is a turn, you see here the turn of the vessel, you yellow the highest velocity. You take a good, swift turn in your car, what will happen? Your car is pulled to the outer side because highest velocity on the outer side. You see that color will be seen here. So if you are tortuous vessel, do expect that different bizarre appearance of colors. Sometime in this manner is a tortuous vessel. So on the outer side, highest velocity, inner side, lowest velocity, so colors will be changed. In the same manner, spectrum will be changed. So in aorta, you have thin waveform line, but if it's this squeezed, vessel is squeezed somewhere, the stenosis, the spectral broadening that you see here, after that squeezing, if you just squeeze a pipe, then the splash of water will go everywhere. It won't go straight. So in the same manner, blood is passing through a squeezed vessel, so there will be a turbulent flow. And after the post-stenotic turbulence, that's called post-stenotic turbulence. So this is a nice normal, this is a post-stenotic turbulence, and and that turbulence is seen like, spectral broadening because so many velocities are seen because there is a lot of stenosis and it's causing the calcium plaques, causing the vessels, the RBCs to splashing as the water splashing in a river in the same manner is splashing against the rocks or the calcium plaques. You get this turbulence. If sometime there is a dissection, an aortic dissection, you get in the same manner the water is dissection, there is a break in the wall and you get a dissecting direction. It will show you in the forthcoming slide, and you get two lumens, double lumen of the vessel. One is a pseudo lumen where there is a break in the wall, it's not having very high velocity, and other is that a tortuous vessel, as somebody else will be talking about fibromuscular dysplasia, this outpouching of the vessel. You see here green, blue, yellow, multiple different colors. On power Doppler you'll get one color because it's not giving you quantitative analysis, but on color Doppler you'll get that sort of picture. If there's a block, there's a dam, totally blocking the river, so RT will be blocked, then collateral will open up. The overflow from the other holes in the walls of the river, and you get these. When there is femoral artery occlusion, you get all these collateral vessels, and these collateral vessels will be showing very different spectrum and different colors. Artifacts. Sometimes we are carried away by the artifacts. The real lady is holding the hand, the man is seen carried away by the artifacts, right? So, all these are not real. So, these artifacts are very useful artifacts sometimes. Rather, in ultrasound and Doppler, we diagnose with the help of the artifacts. The shadowing is an artifact. From calcium plaque, there is shadowing. If artifacts are not there, we can't diagnose the shadowing. In the same manner, reflections are there, which is the basis of ultrasound, right? You see the reflected images over there. This is not real, this is a reflection. But some artifacts, they give us an erroneous, like a duplication artifact, a mirror image artifact. If you don't know that there are mirror image artifacts on Doppler, you will say there are two aortas, two carotid vessels, ghost CCA, but this is not, this is real. So it's very important to know. If you are not sure, change the angle of your scanning. When you rotate the probe, this artifact won't be there. In live session, we will demonstrate how to get rid of the artifact which are taking us away from the real world. But some artifacts, they are used to diagnose. So in color flow finding in peripheral arterial disease, we use artifact at the stenosis. This color bruit. What is the color? First is aliasing. Normal red color is lost. There are different velocities that is called aliasing. We'll discuss it. What is aliasing? When that due to the disease in the vessel, stenosis, the velocities many times increase. While you squeeze any pipe, the velocity will slow or fast. It will be very fast. Rocketing of velocities there, and very, very high velocities, they appear like this. This is called aliasing. Beyond, go anywhere on spectral Doppler, it will go beyond our limits. We will come to that point, how to get rid of that aliasing. A mosaic pattern. You see this mosaic pattern? These are all artifacts. So these tell us, if we are playing with the knobs properly, they tell us something wrong. On color, we will qualitatively come to know there is something wrong with this vessel. Size of vessel is narrowed and the flow through the vessel is not normal. Then what next? We will turn on the spectrum. We can't quantify without spectrum. Let me know when my time is finished for the first lecture. So color aliasing, you see different colors. There are plaques, different colors. So this is the posterior tibial artery and showing different colors. And due to this turbulence in the water, there are so many velocities. These so many velocities are showing those different colors. And color bruit, as you know, put a stethoscope on a vessel which is stenosed, so there is a humming sound. On color Doppler, this again is an artifact. That whole vessel wall is shaken. It's behaving like a angry venomous snake. The vessel is behaving like a angry venomous snake, and it's trying to, like an angry river is splashing, water splashing is there. In the same manner, that vessel is producing so much thrill, the blood passing through it, that the tissue around it is vibrating. and that vibration gives you this color. You see, this is called color growing. The moment I see color growing, I will immediately come to know there's very, very severe stenosis. And before putting the spectrum on, I already make my diagnosis that there is something very high velocities. It must be, so I will set my pulse repetition frequency before turning on the spectrum. We'll come to that point, that when we see that color growing, we are expecting 400, 500 centimeter per second. So on setup for 80 centimeter per second setup of the machine, you can't make anything, you can't measure it. You have to set your spectrum in such a manner that you could quantify that. What happens pulse Doppler finding? There is peak systolic velocity elevated, loss of diastolic flow, growing and TARDIS powers flow. I'll come to those points. Dr. Fahad is also sitting there, she'll be also talking about the arterial Doppler, but I'm just talking about the basic principles. So turbulence flow, spectral broadening, very high velocities. That turbulence flow will be showing. You see here, the color growing can be seen, the tissue is vibrating, and the mosaic pattern. So if you 50 to 69% stenosis, spectral broadening, very high velocity, more high velocity, the narrower is the vessel, the more squeezing is there, and jet goes up, and you get high velocities. The same manner. So what happens to the pre-stenotic segment at the stenosis and post-stenotic segment? What happens to those? So in pre-stenotic segment, velocity will be very low. Then a stenosis very high. Then while stenosis is after post-stenotic, there is dampened post-stenotic turbulent flow, and you see little bit of these spikes here. And after some time, the vessel regains, the next vessel regains its velocity. But you see the rising time? No, the peak is not like this. The peak is going slowly upward, and that is called TARDIS powers. Because when after a stenosis, the speed is not that rapidly going up. That is the basis of diagnosis. Some people say that once certain center, even started in England or other countries, where the cost of scanning the whole leg, I mean from aorta to periphery, was very time consuming. They started a screening program. They just want to know how many people they have peripheral vascular disease. What do they perform? Place your probe at the ankle. Place your probe at the ankle on the posterior tibial artery, and if you see over there that pattern, this pattern, that reflects there is some stenosis in the proximal part. If there is normal triphasic waveform over there at the ankle, the exam finished. That's the screening procedure. If there is that TARDIS powers, slow upgoing wave, spectral broadening, there's no triphasic waveform, then they start performing from aorta to the dorsalis pedis, otherwise they won't. So that was a screening program once it's conducted in European countries. I don't know whether it's still on or not. So how to optimize your image? We have talked a lot about all these things, that how to play with the keys, knobs, and to get a very good, nice, crisp image. How to deal with turbulent flow, a vessel behaving like an angry snake. How to manage that vessel, so get this nice, crisp image. So we have these points, cursor, sample volume, lot of things. I will touch all these things. First of all, the cursor. This is the cursor. How much it should be opened? We mentioned that 1/3 of the size of the vessel it should be opened. Not, it should be touching the wall so that we should get the best velocities. And secondly, what should be the angle? We discussed the angle should be less than 60. If it's more than 60, lot of error. 90, nothing will be seen there. So you have to place this cursor line for the angle and this cursor gate, that how many velocities should be captured, and angle, just to get a good spectrum. Otherwise you won't be able to get that spectrum. That's for the linear probe. If you have a curvilinear probe, then with the trackball, you see here, this line, the angle line, should be along the line of the flow. If this angle line is not lying along the line of the flow, and this angle, this is the angle between this is the line of the flow, and this is the line between that cursor line. Ultrasound beam is coming from here, and this is the angle. This is definitely less than 40, less than 50, I would say. So we'll get a good spectrum. So if this is the vessel, then we are at 90 degree, right? If vessel is this, then at 90 degree, will we get any flow? We won't get. Then this is near 60, the second one. Again, we'll get lot of error. So this is a better, and this angle is definitely less than 60. So that's how to place the cursor line to get a good flow. You have to manipulate that, so that's important. So here you see angle to flow. What is this? This is the vessel wall. What is the angle? 90. So you see very bad flow. Go to and fro. So you get aneurysm. It's not aneurysm. It's a normal vessel. It's quite smooth walls. Absolutely normal vessel. You will make an aneurysm on spectral. So this is now a proper line. This angle is, and you will get a nice crisp image here. And here again you see very nice. So cursor angle correction only used to measure velocity. Cursor is, some people that little bit sample volume cursor is in different machine at different shapes. They try to rotate it that it might be playing with the angle, do something with it. It's not has nothing to do with angle. This line is important, and that another line which makes an angle with the vessel. So this cursor, this is just a sample volume. To get the sample volume, it is not making any angle. For angle, there is another line. You have to rotate the machine. We'll show you in practical session how to get that line. Spectral Doppler, sample volume, we have already discussed that. That sample volume should be 1/3 of the vessel. Size ranges from 1.5 to 30 mm. This, if it's covering the whole of the vessel lumen, we'll get a thick spectrum, might lose good information. If it's normal, 1/3, we get a very good spectrum. And if there's a sample wall is big, you see, it's a very thick spectrum. It's not the true picture of the vessel central velocities. And if we open the gate wide, then we might get both the venous and the arterial flow. If sometime we want to have a qualitative analysis, that we want to know the presence or absence of flow, then it's fine, open your gate wide, you'll get all the velocities going there at venous, arterial, and then you bring that sample volume to the area of interest. Here we are seeing both arterial and venous, both sides, because that sample volume gate is wide open. So what is recommended? The sample volume size should be no larger than 1/3 of the size of the vessel. If larger, the sample volume is capturing slower flow that occurs near the vessel wall, which is not required. Gain, we discussed that as in ultrasound there are gains. In the same manner, there are Doppler gains. If you increase the Doppler gains very high, you see, you can't see this window, you can't see this nice spectrum, and this is very high gain. You do so many things in that, and you can't diagnose. You have to bring the gains down at a proper manner. If your gains are too low, the spectrum will be eaten up. You will lose the spectrum. So it should be the PRF. We were discussing that aliasing. If there is aliasing, the vessel is very narrow. The velocity, rocketing of velocity is 500, 600. Then you have to adjust your PRF. the rate at which the transducer is pulsed per second. If that rate is high, we can measure very high velocities. If that rate is low, that we can measure only low velocities. If we are placing our probe with low PRF on an arterial segment, we get headless peaks. We won't be able to see the upper end of the velocity. So we have to set it. If we are going to scan for veins, I will set my PRF at minimum. If I am going to scan a stenosis, I have seen a mosaic pattern, I have seen that color growing, I will set my PRF at the highest point to get the highest velocity. So, velocity scale have to be set. If it's not set, you see, you will get headless peaks. This is a spectrum, you don't see the peak. The head is cut off. So, you can't measure this. You will be losing, if you measure up to this, you are only measuring about 50% of the velocity. So, you can't do anything if you don't know how to set the PLF. Wall filters. If you set your wall filters very high for a low flow, you will lose all the information. For very high flow, you keep your wall filter at a higher level. Then sweep speed. If it's the fast moving blood and fast moving spectrum, the sweep speed should be high. For venous, it should be, when we want to see the Valsalva maneuver and we want to see the reverse and forward flow, the sweep should be sufficient enough to have all that wave patterns towards the probe, away from the probe, towards the probe and back during the Valsalva, that we do that to see the reflux. And again, that sweep speed is, if it's very slow, we'll have only one part segment of the spectrum. Rest of the spectrum won't be there. So it should be fast enough to capture all the three spectrums over there. Then angle, pulse Doppler signals. How can get good angle to flow? Wall filter, Doppler gain, scale low unless aliasing, adjust gate size and frequency selection. If you can decrease that if you don't get proper PRF.